I'm afraid. Quite a bit of what I have to say is going to seem a bit scary. And I'm going to apologize for that in advance, but it's the way it is, I'm afraid. And I think, certainly from a Verity point of view, we feel that the better educated you are, the better you are able to actually prevent many of the things happening that I'm going to be talking about. So hopefully, education forewarning you is going to be the best way to deal with some of the conditions that are coming up. I'm going to leave plenty of time for questions and answers because I think that's better than that you can focus on what you're really interested in. I'm a scientist and not a clinician, so although I know a lot about the drugs, I'm not good at doses and prescribing and stuff, but I'll do my best if you have specific questions about your treatment. I'm going to start by really talking a little bit about what polycystic ovary syndrome is, because I think it's quite important to set the scene a little bit for what comes later. And it's surprising to me, even with women who have the condition, that they don't quite understand what's happening in the ovary. And really it's not entirely surprising because actually many of us don't really understand what's happening in a polycystic ovary. We're learning all the time, but there are huge gaps in our scientific knowledge about what is PCO and what causes it. Some more exciting things are coming along. If you're interested in how it passes through families or what the genetic cause might be, please do ask me at the end. So let's get started. So what is a polycystic ovary? I don't know how much you know about ovarian biology, but let's pretend not much. Do you know, for instance, that you're born with all of the eggs that you will ever have for your whole life? So during the time that you're in the womb, the eggs move into the ovary and they stay there all of your life. So if you have your last menstrual cycle when you're 55, that egg that you ovulate has been in your ovary for 55 years. It's amazing. Now, each little egg is surrounded by a package of cells, and they're there to protect it, to nurture it, and to make sure that it grows at the right time, so it holds back the growth. So for 50 years, it's sitting there not growing, and then suddenly something one day will tell that egg, it's your turn to start growing. We have no clue at all about what happens in all of that situation. But that little package containing the egg is called a follicle. After puberty, they take it in turns, a few every day, to start growing, and they grow and grow and grow. Lots and lots of them will die, and some of them will make it through to the size at which they can then release their egg. And after many, many years of doing that, you run out of eggs, and then you go into the menopause. So you're born with about 400,000, say 500,000 eggs, and you only ever ovulate about 40 times, so the rest of them will die. It's really about picking the best eggs. So all of the time that those eggs are growing, you're wheedling out the ones that have got something wrong with them, and the very best grade A eggs, the ones with a little lion stamp on them, make it through to ovulation. That's the plan anyway. So the only difference in a polycystic ovary is that you've actually got more of these little follicles sitting in the ovary. We know they're follicles and not cysts, even though we call it polycystic ovary, because they make hormones. The follicles make hormones the same way they do it in a normal ovary, and the eggs inside them are healthy. And we know that because if we give you slightly too much hormone, you can ovulate 9 eggs and have 9 pregnancies. We know that. You can have 9 babies. It's happened. So you can all remember Mandy Allwood. It's exactly what happened to her. So we know the eggs are healthy. We know they're follicles. It should have been called polyfollicular syndrome. It's too late to change it now. So the cysts that you have are nothing at all to do with the kind of cysts that get big in the ovary, that cause pain, that can be cancerous. Nothing at all to do with that. It's just more of the structures that are there in a normal ovary. Now, they're a bit naughty, those follicles, because they make too much male hormone. Very, very slightly too much, nothing like what men make, but women's skin is very, very sensitive to it. And we know, therefore, that that little tiny bit too much male hormone is what can give you extra hair that you don't want and also cause acne. So if you have an ultrasound scan, I don't actually have a pointer, and I'm really, really terrible at using these mice that are this little tiny thing in the middle, but I'll have a go. No, I can't really do it. So what we're looking at here is a transvaginal ultrasound scan of a normal ovary. And the darker shading blob in the middle is the ovary, and the black blobs inside that are follicles. And they're black because they take the sound waves in and they don't send them back to the machine. So they look like black holes. They absorb the sound waves. Whereas the material around in the ovary is a little bit more dense. It sends the sound waves back and it looks a bit whiter. So you see black holes inside a white structure. In a normal ovary, you would probably find 5, 6, 7 follicles at the most at any one time. A polycystic ovary, this is on the same scale, is quite a bit bigger. Again, we really don't understand how it gets to be a lot bigger, but one of the reasons it's bigger is because, as you can see, it's got lots more of these follicles inside. And they're around the outside of the ovary. They're still inside it, but they're around the outside, and it's known as a necklace. So they're sort of arranged around in a necklace. So if you were to look... Oh, fantastic. Try not to laser everybody, yeah. Okay, that will really help. So here's the normal ovary. This is the outline of the ovary, and these are the follicles. Here's our polycystic ovary, and again, these are the follicles, and they're all packed in around the outside. So if you were to look at it in a drawing, that's what you would find. Quite shockingly, about 1 in 5 women in the UK has this appearance of their ovary. It's the most common condition, pretty much, that women have. So how surprising is it that almost no one knows anything about it? It's certainly not something you hear talked about. Most clinicians don't know too much about it, and certainly the general public know very little about it. It's a real shame, and obviously Verity is doing their best to try and get polycystic ovary syndrome out there into the general population. We don't know what causes it, although we're getting some much better ideas. We know it runs in families, so it's almost certainly something that you've inherited. Strangely enough, you can actually inherit it from your father. That may sound bizarre, but you can ask me about that later if you're interested. But we do know it's passed down through families. Lots of these women, these 1 in 5 women who are out there, will never really know they have polycystic ovaries. They may have slightly irregular cycles, but they don't do anything about it because that's what they consider normal for them. They may have a little bit of excess facial hair, but they've never gone to the doctor, so they're not diagnosed. For the rest of you, and that's probably going to be most of the women in this room, you will have some signs and symptoms that make up the syndrome. So you have polycystic ovaries, you have symptoms, you have therefore polycystic ovary syndrome. So what decides if you get polycystic ovaries or you have polycystic ovary syndrome? If they're sitting here on this seesaw, hirsutism is one of the most common complaints, obviously one of the most distressing symptoms of PCO. If you have an irregular cycle, which actually most women with PCO do, it's just many of them don't do anything about it. And unfortunately, if you have weight gain, you're likely to have all of these. It's going to tip you down into having polycystic ovary syndrome. The really important factor here is the weight gain, and an awful lot of what I'm going to talk about this morning will be about weight gain and the consequences of weight gain too. So for those of you who are very slim, who don't really struggle with your weight, or who do but still manage to control it, you're going to be immune from quite a few of the long-term consequences, but not entirely. PCO and weight, it's a real battle. As I say, most of the long-term consequences are because of the weight or because of the insulin resistance, which I'll talk about in a minute. And depending on how you define PCO and what country you're looking at and what population within that country, somewhere between about 20 and 50% of women who have polycystic ovary syndrome will be overweight. If you look at people in the States, actually even sort of 40-year-olds in the States now, the majority of women with PCO are overweight. They are really struggling with obesity massively. And you're probably aware this is going to be Michelle Obama's big push. She's going to try and deal with obesity in the States. Well, God bless her. Let's hope she manages it. But she's up against a real tough one. So why do women with PCO put weight on? Unfortunately, you've got probably, again, a genetic condition, which means you're really fantastic at preserving calories. So the calories that come into your body stay there, whereas the rest of the population who have normal ovaries are much better at getting rid of them. About 400 years ago, if you had polycystic ovaries, you probably lived when people around you died in famines, because you were able to live on a lot less calories. And that's probably one of the reasons why it's become so common, because it was actually a means of survival. Nowadays, of course, we have too much food, not too little, and so it does exactly the opposite. It's just what you don't want. If you look at the way that you save calories, it turns out to be about 17,000 calories a year. So, say about 100 Mars bars. You might think, well, that's not that much, but actually, you know, it really is. So you've got to eat about 17,000 calories less every single year, and that's about 2 kilos of fat less every single year, just to stay the same weight as someone who's got normal ovaries. It's deeply, horribly unfair. If I had to lose 4 pounds every year, I don't think I could do it. I really don't think I could do it. So if you've managed to do it, or even if you've managed to only gain 1 kilo a year, you've actually been doing pretty well. So let's have a look at how that would affect you across your life. Say you start to show signs of PCO at the age of 15. This is your weight gain in kilos. By the time you're 26, you will have gained 20 kilos in weight, even if you've just had the same diet as your sister who happens to have normal ovaries. So if you've managed to gain less than 20 kilos, you're doing very well. You're doing something right. It's a real struggle, isn't it? When you look at it like that, it's going to be a really hard battle to win. We always talk about BMI, and you need to be in this range of BMI. What does actually BMI mean? Again, a lot of people don't really understand BMI. BMI is really just a way of telling you how fat you should be according to your height. It's a bit of a complicated sum to do, but it is worth getting to grips with, because you will constantly be told what your BMI should be. So you take your weight in kilos, which of course, being British, we don't know what kilos are either. Hopefully you've got a pair of scales that were born this century and have both on. I actually don't. I've still only got stones on my scales, unfortunately. And you can read off your kilos, your weight in kilos. Then, of course, you've got to deal with meters, which none of us actually know our height in meters, I shouldn't think. Actually, I'm probably a bit older than most of you, so maybe you do start to know more about meters. Then you've got to times your height in meters by your height in meters, and then divide it into your weight in kilos. It's not an easy sum, there's no doubt about it, but have a go, see what you can manage to come up with. So, if we take the whole spectrum of weight of women, normal, we've just actually moved the normal range. We haven't, just because the nation's getting fatter, we've actually moved what's normal. It doesn't mean actually we should have got fatter, but we did it. So, normal now has gone from 19 to 20, up to what used to be 24 is now 25. So, a fairly narrow range actually is considered to be normal. If you're seriously underweight, we do actually amazingly have someone at St George's at the moment, an inpatient who's got a BMI of 10. Yes, probably actually not going to live, unfortunately. But this is really the underweight range. This is considered overweight. So if you have a BMI of 26 to 30, you're considered overweight. And then when you get from 30 upwards, you're considered obese. It's a horrid word, obese, isn't it? I really don't like it at all, but anyway, we're sort of stuck with that as well. So what does that mean? If you are my height, so 5'7", or in proper speak 1.6 meters, if I was to weigh 8 stone, so if I lost 1.5 stones, I would have a BMI of 18, I would be underweight. 10 stone would give me a BMI of 25, so that's up at the... So I'd only have to gain 1 stone to be considered overweight, and then as you go up, you can see getting up to about 90 kilos will take you up into the obese range. Now, why is being overweight a problem? Well, it's a problem for everybody, but it's a particular problem if you've got PCO because it makes everything much worse. Quite a lot of the carbohydrate that we eat is converted into insulin, and it's actually insulin that is the thing that's causing a lot of the damage. So, after we eat a meal, the glucose in the meal is the carbohydrate in the meal is converted into glucose. Glucose goes up in your bloodstream. That's good because your muscles need glucose. You then make insulin. Insulin takes the glucose out of your blood into the muscles so you can use it as energy. Now, as we get fatter, we need more and more insulin to get that glucose out of the blood and into the muscles. That applies to everybody, whether you've got PCO or you've got normal ovaries. The big problem if you've got PCO is that you need even more insulin. So as you put more weight on, you need much more insulin to try and keep getting that glucose out of the blood. And eventually that means you're likely to have problems balancing your glucose and your insulin. And that condition is known as insulin resistance. So it's as if your body just can't quite see the insulin that's there, so you have to make more to tell the body, look, there's glucose, get it out of the blood. I think insulin resistance is going to be covered again in the next speaker and probably the one after, so you're going to get this message quite loud and clear, I think, by the end of the day. Insulin resistance also runs in families, and we now see, if we take the brothers of women with PCO who have insulin resistance, we find many of the brothers also have it too, and actually quite young. So we've got 17 and 18-year-old brothers at George's who've got insulin resistance, and often the parents also have got diabetes, so it's really running in the same families as the PCO is. Now, if, as I say, as you gain weight, you get more insulin resistant. If you've got normal ovaries, it's pretty much a straight line. The fatter you get, the more insulin resistant you become. Now, the big problem is if you've got PCO, you end up with a line like this. So, as you put weight on, instead of the insulin resistance going along here, it gets worse and worse and worse, faster and faster. So you're much more likely to run into problems at a much lower weight than someone who's got normal ovaries. Now, the good thing about this curve is that if you're coming this way, you're coming down the curve much faster as well. So as you lose weight, you're correcting your insulin resistance much faster than someone with normal ovaries as well. It also means you don't have to lose a great deal of weight. Even a little bit will really shift you down that curve. So even tiny bits of weight loss can really be helpful. So why is too much insulin bad for you? Well, while you're young, your pancreas, which makes insulin, is quite happy throwing out all that extra insulin to keep the glucose down. But after a while, it starts to get tired. It just can't keep pace with making all that extra insulin. And the glucose, therefore, in your blood starts to drift up. And that is what will do some of the damage. You don't want high levels of glucose. It's starting to get towards diabetes. So after a while, when you eat a meal, it's going to take a lot longer for the glucose to come down, and you're going to have a condition known as glucose intolerance. And that's really the first sign that you're likely to get diabetes later in your life. But it's reversible. If you really lose weight and you build muscle when you're glucose intolerant, you do have a chance of delaying or stopping that conversion into diabetes. Unfortunately, we know over time women who are insulin resistant and glucose intolerant are much more likely to go on and develop diabetes. For most of them, no one ever tells them they've got a high risk of diabetes. It's something we've not known about for a long time, so they've not had a chance to do something about it. The type of diabetes that you're likely to get is the maturity onset sort, what's known as type 2 diabetes, so not the same kind as little children get where they need insulin. But the shocking statistic is that women with polycystic ovary syndrome are about 5 times more likely to get diabetes later in life than women with normal ovaries. It is a very scary statistic. It comes up over and over again, no matter what studies you look at. In the States, it's much higher than that because they're so much fatter than we are. But we're doing a good job as a nation to try and catch them up, believe me. It's depressing, but we are. Women in Southern Europe have a much lower risk. Actually, they don't seem to convert to diabetes. And if you're slimmer, your chances are a lot lower. And if you're more overweight, the chances are your risk will be higher than 5 times. It's very worrying, and hopefully something that you'll go away and read about and will give you that extra jolt into thinking, you know what, I really need to think about this long term. If you're very slim and fit in the audience, I beg your pardon, you probably don't need to know this because you won't be affected. So, insulin is bad for you all round, high insulin. It's more likely to reduce the number of cycles you have per year. You're less likely to respond to infertility treatment if you need it. You're more likely to need more drugs to get pregnant. You're more likely to get gestational diabetes. It's one of the first signs that you're insulin resistant. And unfortunately, you're more likely to have a miscarriage if you then do manage to conceive. So having high insulin, high glucose in your blood is bad news all the way around. Okay, so let's move away from insulin and look at some of the other factors that you're going to have to be concerned about for your long-term health. One thing we know about women with PCO is that when they put the weight on, they tend to do it in a slightly different way to women who have normal ovaries, in that there's an increase in fat going on around the middle. So if we take these 2 women who are exercising, if you've got PCO, you're much more likely to have what's called an apple shape, so the weight goes on here in the center, rather than it being on the hips and thighs, which is what women with normal ovaries tend to do. So often women with PCO have got really good legs, but then above the hips, they start to get the weight put on. Unfortunately, putting weight on in the middle is much more dangerous for your heart. It's the kind of fat that men put on. I'm sure you're all aware that men tend to put fat on around the middle rather than on their hips. It's one of the things that makes men have a higher risk of heart disease. Now, on top of that, unfortunately, women with PCO also often have an unhealthy lipid profile. So that is the fats that are circulating in your blood. And the main one that you're going to be concerned about is cholesterol. Now, when you have a cholesterol measure, they give you 1 number. And it's helpful, but it's not as good as it could be, because there's actually 2 kinds of cholesterol. One is low density, and the other is high density. I don't know how much you know about this, but what you're really bothered about is how much of one you've got compared to how much of the other. The high density one is good. you'd think it'd be the other way around, wouldn't you? You think something that was heavy would do a lot more damage, block up your vessels, but it doesn't. High density cholesterol is the one that's good for you. You want that to be as high as you can. Low density cholesterol is the one that does the damage, and you want that to be low. Unfortunately, if you look at the balance in women with PCO, for women of the same weight even, we know that they tend to have it the wrong way around. They have too much of the low density and not enough of the high density. So, say you have a cholesterol of 5, then most of that will actually be the good one, about 3 to 4 will be the good one, and about 1 will be the bad one. You want to get it the other way around. So you would want, sorry, I've just done that the wrong way around, haven't I? Just to confuse you all. Most of that's going to be the low density, and less of it will be the high density. The average cholesterol in the UK at the moment is about 5.5, and about 20% of us have a cholesterol over 6.5, which is considered to be in the higher risk amount. Interestingly, that's about 50% of people in the UK and the US. So almost half of people in the US have a cholesterol that's considered to be in the risk category. It's quite a scary statistic for a nation, actually. So what's a healthy cholesterol? We have no clue. There are debates going on all over the place, all over the time. But looking at what happens to people long term and going back and looking at what their cholesterol was, the best clue we have is about 5.2. So 5 is great. Anywhere between 5, 5.3 is probably okay. So that's what you're aiming for. If you can get the ratio, even better, because it's the ratio you're going to try and tweak to make you more healthy. Now, as if that wasn't bad enough, we also have another kind of fat circulating called triglycerides. And again, unfortunately, they are too high in women with polycystic ovary syndrome. However, they tend to be almost entirely associated with obesity. So if you can get the weight down, the triglycerides tend to come down with it, whereas cholesterol takes a bit more shifting. Early in life, for women, actually, triglycerides tend to be much lower than they do in men. And then later on, if you've got PCO, they're likely to increase, and we think as they increase, they actually do more damage than higher levels in men. So keeping your triglycerides down is, again, really important. And that's about reducing fat in your diet. You can have an impact on your triglycerides by reducing the kind of fats, particularly animal fats, actually, that you have in your diet. So we're looking now at obesity, at insulin resistance, at having bad fats in our blood. Unfortunately, women with polycystic ovary syndrome also have the final thing that is a bit of a bad news, and that is high blood pressure. We know that having too much insulin causes high blood pressure, so everything you can do to get your insulin down will also not only bring your blood pressure down, but maybe help you to stop getting high blood pressure in the long run. Women with PCO tend to have higher blood pressure rather earlier than women with normal ovaries, and over the lifetime they're going to have quite a higher risk. We know they have about 3 times the risk of getting high blood pressure in pregnancy, the dangerous kind of high blood pressure. Again, it's always worth telling the clinicians, the obstetricians, if they don't know you've got PCO and you're presenting pregnant, about your polycystic ovary syndrome, because you're more likely to have diabetes and you are more likely to have high blood pressure. Often it's not something that's asked when you are presenting to an obstetrician. If you look at a blood pressure clinic, so these are women who've got blood pressure later on in life, and you try and take a history and find out if they might have had PCO, you find that women with PCO are there about 3 times more likely than they should be. So about 3 times more of the women in the clinic will have PCO than ought to be there. We don't know if blood pressure is entirely due to the fact women with PCO put weight on, or if it's something that women with PCO are going to get anyway. But again, it's probably to do with the weight. So we're going to be more obese, we're going to have fat in the wrong place, we're likely to get more diabetes, we're likely to have hypertension. We know our circulating fats are not going to be good for us. What does all this mean? Obviously, the really scary thing is that we're going to get a much higher risk of having cardiovascular disease. Do we get more cardiovascular disease? We actually don't know. Wouldn't you think by now we'd really have the data to tell us whether women with PCO are going to get more heart disease or not? We don't. Some studies say yes, they really do, and some studies actually say, you know what, it doesn't look like they're going to. So the good news is that probably the differences are not huge. If we knew for sure that women with PCO get a lot more heart disease, we'd have found it by now, and we haven't. However, don't rely on it. The problem is that the data really aren't there. A lot of the studies that have been done haven't got enough women in them. If you're looking at reasonably rare events, and heart disease in sort of 60 to 70-year-olds is still a little bit less common than it might be in men, for instance, you need a massive number of women to really find differences, and we haven't done those studies yet. The other problem is the women are too young in the studies. So the really big study that was done, which showed no difference at all except for a slight increase in stroke, the women were only 50 to 60. They're just not old enough to have really had the heart disease happen. And the really big problem is, how do you take a group of women who've got heart disease, so probably 70, and find out if they've got PCO? You can't scan them because it's not going to tell you anything. Their ovaries will be shrunken and smaller at that age. So all you can do is ask them about their history. Did you have irregular cycles? Did you have miscarriage? Did you have problem with hair? And then you can get some clue about who might have had PCO. But you're really looking at a marker of PCO rather than PCO per se. So I think all of these things are just stopping us getting the data that we need. What do we know? What are the hard facts that we actually do know? We know, for instance, that if we look at risk factors, so the high fats, the cholesterol, the heart disease markers, you've got much less risk if you're slim and just say have high androgens, so problems with your skin, than a woman who is overweight or obese and already is starting to show problems with her insulin. We can be absolutely certain that the overweight woman will have a higher risk, and the normal weight woman is going to have, if anything, a much lower risk than the other lady. What we've been trying to do is measure things that give us a clue about what might happen in the future. So we do, for instance, know some things in the blood give you a clue to your risk of heart disease, and these are fairly high-tech measurements. They're not done routinely in clinics. They're done for research purposes, but they're actually pretty good markers of your future risk of getting heart or vascular disease. So there are things you can measure in the blood. You can also look at how elastic someone's blood vessels are, because the stiffer they get, we know the more chance you have of having cardiovascular disease in the future. And you can actually look at early signs of blockage. So you can look at someone's vessels in their neck, for instance, where they're easy to look at with a scan, and you can look whether they're starting to get little blockages. All of the studies that have been done in younger women show that all 3 of these things are worse in women with PCOS. So it's very hard to think that there isn't going to be at least some risk in the future of getting cardiovascular disease. Okay, let's move away from all that really scary stuff and think about what actually happens to the ovary. Because lots of women say to me, what actually happens to a polycystic ovary when you hit the menopause? We know you're going to run out of eggs, and without eggs, you don't have follicles. The follicles in the ovary will disappear. The ovary is going to get smaller, but actually it's still a bit bigger than someone who went through their life with a normal ovary. And people have been scanning menopausal women who have a history of PCO and trying to see if they can actually pick up who had polycystic ovaries. Because then we could do the studies in the older women and look for heart conditions. They haven't cracked it yet. It really isn't going to be very simple. The follicles are where most of those excess androgens that do the damage to your skin are coming from. So when you lose your follicles, the androgens will drop. The problem is that you're going to carry on making androgens from the adrenal glands, and they will stay, unfortunately, slightly higher. So if we look at androgens with age, if this is someone with normal ovaries, at puberty, their androgens will start to go up slightly as the ovary gets working, and the ovary gets bigger and bigger, even in a normal woman. By the age of about 30, unfortunately, your ovary is already considered biologically a bit over the hill, and you're on this downward slope. It's very depressing, isn't it, to think that's actually happening at 30, but unfortunately it is. By the time you get to 40, your androgens will be back about where they were at puberty, and then they pretty much stay level because the adrenal takes over and the ovary pretty much stops making a lot of them. In PCO, they actually start a little bit higher, even at puberty. They're going to go up quite a bit more in most women than they will if you've got a normal ovary. And then they actually come down again as you start to go towards the menopause, but they will stay consistently higher through the menopause. We don't really know what that means. We know one good thing: it's good for your bones. So the androgens work the same way as estrogen and will help you to keep strong bones. We do know that. The problem is those androgens may also contribute slightly to your risk of getting heart disease. Again, we just don't really know if that's true. One thing you may notice as you get towards the menopause, and partly because of this fall in androgens, is that if you've had irregular cycles, they may start to get more regular. Probably not going to be a great deal of help at that point because, again, we're talking about people who are becoming perimenopausal. But it is something that women often say, oh, my cycles got more regular. We don't know, as I say, whether higher androgens later in life are going to make you have this slightly higher risk of having heart disease, and whether these high androgens are the thing that is responsible for giving you the bad kinds of cholesterol, which is what men are more likely to have. Unfortunately, estrogen falls at the same time as your androgens fall, and if anything, that's going to contribute to you putting any fat that you gain later in life around the middle and not around the hips. It's not what you need. Again, it's likely to make your insulin resistance worse, but again, we don't know whether that's entirely because everyone, as they get older, tends to put weight on, or if it's about polycystic ovaries by themselves. One thing that we do know is that even a tiny bit of exercise across a number of years really makes a big difference. Quite a few studies coming out now, particularly from Australia, where they've been following women who have only been doing 30 minutes walking a day, and I'm sure most of us can manage that. It's made a big difference across a number of years. 30 minutes a day of walking for many years actually really made a difference to what happened later in these women's lives. Another bit of a scary one here, but I think it's important to try and tell you what we know, what data are out there. Very little at all about breast cancer and PCO, but we do know that there are some markers that give you a higher risk for breast cancer. One of them, unfortunately, is obesity, probably because there's a bit more estrogen around if you've got more fat. We know infertility is linked to breast cancer. Again, we really don't know why. And again, we think that higher androgens may also give you an increased risk of breast cancer. But there's been two pretty good studies, both done in the UK, so we know we're looking at ourselves here. Neither of them showed any increased risk of breast cancer in women who had polycystic ovary syndrome. So that's quite reassuring, I think. We do know, however, that if you have a family history of breast cancer and you've got PCO, you seem to be a bit more likely to inherit it. So if you have a family history of breast cancer, it may be well worth being a bit more careful about making sure you get your breast scans done. And finally, and this one I think is quite serious actually, and we do have reasonable data to suggest that there really is an increased risk of endometrial cancer. So why is that? What's endometrial cancer? So if you think about your womb, the muscle of your womb, it actually has a lining that builds up every month and you get rid of it, and that's called the endometrium. So the lining of the womb is what builds up every month and then you get rid of it. In the first half of the cycle, so while you're having your period up to the time at which you ovulate, you're making lots of estrogen, and the lining of the womb loves estrogen. It gets thicker and thicker because it's thinking, oh, maybe a fertilized egg coming, I want to be able to catch it. So the womb lining gets thicker and thicker in response to estrogen. In the second half of the cycle, after you ovulate, you make the hormone progesterone. That keeps the lining thick, but it doesn't make it any thicker. But then if you don't get pregnant, progesterone falls actually very fast, and the whole lot is shed, and that's your period. Now, if you don't ovulate, or you ovulate irregularly, you're not going to make the hormone progesterone, or you're only going to make it infrequently. So you won't have a fall in progesterone, so you'll never shed the lining of the uterus. And the big problem with that is it's going to see lots of estrogen because you're all making estrogen, and it'll get thicker and thicker and thicker. Sometimes it's going to get so thick it just can't sustain itself, and you'll have a bleed even though you haven't ovulated. And those are the kind of bleeds that are the really bad ones. They tend to be very heavy, you're probably passing clots, can be quite painful. Those are the bleeds that are usually caused by the endometrium being shed just because it's got too thick. In the worst case scenario, those kind of bleeds can become a little bit uncontrolled, they can last a long time, and they may result, if you do them regularly, in you having anemia. And many women actually with PCO are anemic without really realizing it. And I often think that's one reason why women with PCO report that they're quite tired. Actually might be worth, if you're having irregular, very heavy cycles, might be worth getting your GP just to check that you're not anemic. Now the really worrying thing is if you repeatedly have these heavy bleeds, irregular bleeds, long periods in your life where you don't bleed and then you have a heavy bleed, you're more likely to have these changes in the lining of the womb, which are called endometrial hyperplasia. And it's where the cell division just gets a little bit out of control. It's easy to diagnose, you just need to get a little bit of the endometrium and have a look at it. But what's really worrying is that about 15% of cases of endometrial hyperplasia will go on to become endometrial cancer. It's quite a rare condition, but we know that over a lifetime of having irregular, heavy cycles, you will increase your risk of having endometrial hyperplasia. So all of these things are risk factors. Many of these things are present in women who have PCO. How do you know if you've got endometrial hyperplasia? Well, you don't, unfortunately, but if you have heavy, irregular bleeding, if your bleeding lasts for up to 2 weeks, or particularly if you're bleeding between periods, so if you're bleeding every couple of weeks, that's a real signal that you should go and get someone to have a scan, see how thick your endometrium is, and if need be, take a little sample of it. It's quite easy to do. You just go through the cervix with a little instrument, take a piece, and have a look at it under a microscope. Two big studies really to date with the right sort of numbers of women. One showed a very scary 3 times risk of getting endometrial hyperplasia, and the other showed no risk at all. So what does that tell us? It's confusing, there's no doubt about it. But I would think there is a risk, really. If you talk to the surgeons at St George's where I work, they say most of the women they see with endometrial hyperplasia have got polycystic ovaries. So don't take the risk. You need to lose your endometrium about every 3 months. You can choose how to do that, or you can not get endometrial thickening in the first place. Combined oral contraceptive obviously is going to do it because you'll be bleeding, but you know, most of you aren't going to want to take that if you're overweight or you've got infertility. You don't want the pill, obviously. There are other ways to do it. You can have a Mirena coil that will release progesterone locally and stop the endometrium getting thick. Again, that's no good if you've got infertility. You're not going to want a coil. But there are lots of things that you can negotiate with your gynecologist or your GP to make sure you don't give yourself that risk of endometrial hyperplasia. I know I'm going over a bit of time here, but this is another thing that actually is quite important, and we're only just really getting to be aware of it, that women with PCO have a much higher risk of having this condition called sleep apnea. So, you may be aware of this. It's normally something that men get, actually, and it's where if you're lying there listening to your partner in bed at night and he's going breathing, snoring, and then he'll suddenly go and wake himself up. Yeah, we've all been there. We know that one, don't we? Or you give him a bit of elbow. You're snoring again. What we know now is that actually women with PCO seem to do this quite a lot as well. And it's not just to do with weight, which is what we thought. It's something about PCO in particular. The big problem with it, not just that it drives your partner crazy, but it means you're not getting long, uninterrupted times of sleep because you keep waking yourself up a little bit. It's going to make you feel very tired during the day. And something we've noticed at George, actually, if you go into the PCO clinic, about half the women sitting waiting for their appointments have dozed off. I bet you they've got sleep apnea. If someone tells you that you're doing this in the night, it's well worth thinking about going and getting it sorted, because there are treatments for it. You will feel much better if you've had long periods where you're not waking yourself up over and over in the night. So I just wanted to put that in because it's something we're becoming more aware of. So the overall message, it's a bit scary, and I'm sorry about that, but I think it is important that you know about it as young as you can so you can do something about it. Most of it's to do with weight and high insulin, and we do also suspect that some of the additional risk for heart disease is about having high androgens. I was going to talk a little bit about diet, but I've run out of time. So if you've got questions about diet or exercise, I'm happy to take them. Finally, I'd just like to say thank you very much to you. It may seem a strange thing to say, but I'm thrilled to bits that there's lots of PCO out there because it keeps me in a job.